Thank you all for being here this evening. We're going to be talking about the need for continuing medical innovation in psoriatic arthritis and treating immune disorders to improve outcomes. My name is Randy Baronic. I'm President and CEO of the National Psoriasis Foundation, and I am joined to my left by two of the finest rheumatologists in the United States and a patient volunteer from the San Diego area, Dr. Chris Richlands at University of Rochester, Dr. Elaine Husnes at Case Western University, and Noella Ferrara, I'm going to miss that name one more time, I think, tonight, is a NPF, a National Psoriasis Foundation volunteer from right here in San Diego, who lives with psoriatic arthritis. We're going to hear more from all three of them in just a moment. The format, I've got a few opening remarks to talk about the state of psoriatic arthritis, how the National Psoriasis Foundation as a patient advocacy organization goes about attacking this issue. And then we'll hear from our two rheumatologists and patient advocate volunteer on different elements of how they see this current state of psoriatic arthritis. And then we'll have some time for questions at the end. So if you could, we'll go through all of our presentations before taking questions from all of you because we want to save time for that. Okay, I'd like my first slide. We can get that up. Psoriasis and psoriatic arthritis are very serious diseases. They're chronic, they're progressive, they're autoimmune diseases. For those of you who don't know a whole lot about psoriatic disease, it's the most common autoimmune disorder in the United States. And it's more than just a skin disease. It's more than just joint pain. These are diseases that affect the entire individual in just about every aspect of their life. There's also comorbid conditions with people that have psoriasis and psoriatic arthritis. People in that population are much more prone to cardiovascular disease, premature cardiovascular disease, type 2 diabetes, kidney disease, certain forms of lymphoma are all comorbid conditions of people with psoriatic disease. And as we go through this, I think it will point out the need for us all to join together and treat these diseases more aggressively, because you'll come to find out just how startling the statistics are related to how we're not doing a very good job of managing these diseases. The prevalence, in just psoriasis alone, there's about 7.5 million people in the U.S., 125 million people globally. About almost 1/3 of these people will develop psoriatic arthritis at some point. Okay, thank you. About 1/3 of those people will develop psoriatic arthritis during their lifetime. Next slide. There's largely unmet needs, as I mentioned earlier. Of that psoriasis population, some 1/4 of those people currently have undiagnosed psoriatic disease. And as you'll hear later on, psoriatic arthritis is a progressive disease. And if you think about the delay in diagnosing this very serious disease, how much damage is done in that time in which symptoms, the onset of symptoms, until the time of diagnosis and then subsequently treatment. Almost 2/3 of the patients with psoriatic diseases are not satisfied with their current method of treatment. And 90% of people with psoriatic arthritis report it to be a problem in everyday life, and about half of those people say it's a really big problem in everyday life. So why are there these unmet needs? There's a lot of different reasons, but most of them are fall into these three categories. Access to care. About 40% of the people who are not treating their disease say it's due to cost. But there's also reasons that are found in our own current medical system. Most of the people, one of the things you'll see here is about 50% of people with psoriatic arthritis are not seeing a rheumatologist. They're getting treatment from some other, either specialty or just a general practitioner. So that's why many of them that's a large contributing factor to people that are unsatisfied with their current method of treatment. Delayed diagnosis, as I mentioned before, about 29% diagnosed at least 2 years after their first sign of symptoms. And then finally, the patients themselves. About 28% of the patients that are not treating their disease just have given up. Nothing seems to be working for them. The right tools are not in the marketplace for them. And then a smaller percentage obviously fear side effects from these treatments. So what does the National Psoriasis Foundation do? What is our role in all of this? We really are focused on 3 different areas. First, advocacy, and we kind of lump advocacy into one big bucket, but it really boils down to access to care issues. We spend an awful lot of time and resources trying to help patients get the coverage that they need, and trying to preserve that physician-patient relationship, and the decisions that are made in that process are paramount in our minds. And so we spend a lot of time helping patients, helping healthcare providers navigate through the seas of health coverage. And we also do a lot of government relations work on legislative initiatives that are important to our community. In the area of, the second area that we're engaged in is research and medical education. We take a multi-pronged approach to scientific discovery. We see the National Psoriasis Foundation as a catalyst in scientific discovery. We simply do not have all the resources needed to invest in the best ideas in psoriatic disease research. So we have to partner with other organizations trying to bring more people into the science of psoriatic disease. We do fund research ourselves, basic science, translational science, that the results of which get closer to what goes on in an R&D laboratory in a pharmaceutical company that actually will develop these therapies that are effective in treating these diseases. But training medical professionals, not just rheumatologists, not just dermatologists, but allied health professionals. Many of these patients are spending most of their time with a physician's assistant, a dermatology or rheumatology nurse, someone other than a physician. And then we try and entice people with early career training for residents, medical school residents that are dermatology or rheumatology residents that haven't really decided what career path they're going to take. Providing them funding to get experience in psoriatic disease research so that they are interested in becoming a clinician scientist throughout their career. And then obviously on the patient side, if you're a patient that is managing your disease anywhere outside of a clinical setting, seeking resources to help manage your own disease, looking for support, you're probably coming to the National Psoriasis Foundation. So we have extensive patient education tools and programs that we're involved in. Next slide. I do want to say to all of you who do not know, we are on the eve of World Psoriasis Day. Tomorrow will be, it's commemorated every year on October 29th. Really? It's a day conceived by patients, for patients, and celebrated throughout the world. The National Psoriasis Foundation has some 43 or 44 sister organizations, patient advocacy organizations in countries around the world. And we all celebrate World Psoriasis Day and take the opportunity to raise awareness of the disease and its impacts, and provide information to the patient, and provide support to the patients and their caregivers about psoriasis, and trying to eliminate the stigmatization and misconceptions that happen about the disease around the world. So go to psoriasis.org tomorrow and see what World Psoriasis Day is all about. And then lastly, the problem with psoriatic disease is something that we all have a stake in. And this final slide shows all the different components or constituents that need to play a role in us for us to be effective in battling this disease. And everyone in this room falls into one of these categories. And so by virtue of your being here tonight, you've obviously made the first step in trying to contribute to the elimination of psoriatic diseases, so I thank you for that. Okay, now it's my pleasure to introduce to you Dr. Chris Richland. He joins us from the University of Rochester Medical Center, School of Medicine and Dentistry. Dr. Richland's research efforts are directed toward the understanding of mechanisms that underlie pathologic bone resorption and newborn bone formation in psoriatic disease, psoriatic arthritis, and rheumatoid arthritis. He is the director of the Clinical Immunology Research Unit, where he is a principal investigator on several different clinical trials, testing the efficacy of several agents in the treatment of psoriatic arthritis, rheumatoid arthritis, and ankylosing spondylitis. He's also happens to be a dear friend of the National Psoriasis Foundation for a very long time. He's a member of the National Psoriasis Foundation Medical Board. So please welcome Dr. Chris Richland.
Thank you, Randy. It's a pleasure to be here. I should mention that both Dr. Husney and myself are awardees of grants from the National Psoriasis Foundation, which have really been critical in helping us to advance understanding of this disease. So what I wanted to start with is just to tell you that there are about 305 million Americans, and about 4% of them get psoriatic arthritis. The numbers are between 7.5 and 12 million. And about 30%, as Randy told you, will develop psoriatic arthritis. And next slide. So that's really interesting is that the gap between the onset of the skin disease, which usually comes first, and the arthritis is on average 10 years. So that gives us an opportunity to really search for arthritis and psoriasis patients, and our laboratory has been working very hard to do that. Now, this disease can be very debilitating, as Randy mentioned, and these slides here just give you some inkling of the diversity of the types of problems that patients with psoriatic arthritis can develop. So on the upper left-hand corner, you see an MRI of a patient showing on the upper part of it. I know you're not used to reading MRIs, excuse me, but there's new bone formation in the spine that's causing the spine not to move well and compressing the cord. You can see the hands have severe damage with the joints being totally resorbed. And these are the same findings in one patient in two different joints. On the left lower corner is a patient in my practice who came in with their fingers fused, and you can imagine that really inhibits function. And then on the x-rays on the right showing you that you can have extensive damage to many of the fingers and the hands. And way to the right is a young woman that came in with back pain. And again, I know you're not radiologists, but I think you can see if you look to the right of the spine there that there's a lot of new bone being formed. So psoriatic arthritis is notorious for causing a wide array of changes in the joints that can be very debilitating and impair function. Next slide. This slide illustrates that even within a single hand, that the changes can be quite dramatically different, ranging on the left-hand side, the little finger, with that joint being destroyed, or looking over to the finger next to it, having diffuse inflammation. Again, I just want to illustrate to you that this disease is highly pleiotropic, meaning it has many different forms, all of them highly destructive. Next slide. So what's really important to emphasize and underscore, and Randy already mentioned this, is that psoriatic arthritis does not occur in isolation. It occurs with psoriasis, which is associated with not only skin plaques and a sense of a lack of sort of appreciation of how severe, but many people don't appreciate how severe this can be to a person's psyche. But many of these patients have other comorbidities, meaning they're often obese, and that may be driving the disease, interestingly enough. They have an increased risk of cardiovascular disease as well as diabetes. Patients can develop eye inflammation and Crohn's disease. And then the musculoskeletal circle shows you all the different forms of arthritis that one can see with psoriatic arthritis. This is very different from rheumatoid arthritis, the other common inflammatory joint disease, which is much more stereotypical in its presentation and not so diverse. Next slide. So this slide illustrates for you the variety of comorbidities, again, mentioned by Randy. I just want to highlight once more that the obesity and metabolic syndrome are really a major problem in this disease, and again, are part and parcel of the arthritis and the psoriasis, as well as depression and anxiety, which are very common. You can well imagine that if you have skin inflammation accompanied by inflammation in your joints and trying to deal with type 2 diabetes and metabolic syndrome, that this is a high stress on your psyche and on your functioning. And this is really something that we focus on and we're trying to address more globally. Dr. Husney as well will tell you about this as a major focus of her team. Next slide. So what are the major gaps in this disease? Well, up to 45% of psoriatic arthritis patients do not respond to traditional disease-modifying agents or anti-TNF agents. We lack biomarkers to help us predict which patients might respond to a specific treatment or not. And we also lack markers, as I told you at the beginning, as to what are the factors in psoriasis patients that may lead them to develop arthritis, with the knowledge that psoriasis precedes arthritis by about 10 years in most patients. We're also limited by the high cost of biologic agents, which are beyond the means of many of our patients, particularly in areas outside of the United States where it's very hard to get these medications. We also know that there's a lack of knowledge regarding the factors that link the psoriasis and the arthritis, and we need treatments that address the whole disease, meaning the skin disease, the arthritis, and all those comorbidities that I just showed you. Next slide. I belong to a group, and so does Dr. Husney, called the GRAPPA, the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, an international group of dermatologists and rheumatologists dedicated to trying to find more effective treatments for this disease. And in order to do that, we've had to understand that this disease has a wide variety of manifestations shown on the top of this slide, which include not only arthritis and psoriasis, but enthesitis, which is inflammation at where tendons insert onto bones, dactylitis, which is swelling in the fingers of the hands and the fingers and toes of the feet, and then disease in the spine. An individual patient can have all of these together or individual facets of each of these, and you can imagine that taken together, this can cause a great deal of pain and problems for individual patients. So on the left-hand side are the various treatments that are available for psoriatic arthritis, and we've been working to update and treatment recommendations based on the evidence that's out there based on clinical trials. Next slide. So this is showing you the anti-TNF response in green. So along the bottom are infliximab, golimumab, etanercept, adalimumab, and the recently approved drug certolizumab, and these are anti-TNF agents. And what you're seeing in green and on the left are the percentage of patients that respond to these agents, and the leftmost green bar in each medication is what's called the AACR 20, and this is giving you the data from the phase 3 trials. All of these drugs are approved for the treatment of psoriatic arthritis. And 2 points from this slide. One is that the response to the different anti-TNF agents is pretty similar, almost identical, interestingly enough, whereas the response to the skin is better with the antibodies, which include infliximab, golimumab, adalimumab, and certolizumab, than with etanercept. So these are effective medications, but you need to think about it in reverse. What's the percentage of patients up there that are not responding? And it's about 40 to 50%. So despite the fact that we've been able to, that these drugs have been a game changer since they were introduced in 1998, we still have a tremendous unmet need. Next slide. So this slide shows you the various therapies that we have out there for rheumatoid arthritis and psoriatic arthritis. I won't belabor the point except to emphasize that there are differences. So not all the drugs that work for rheumatoid arthritis, for example, work for psoriatic arthritis. And Dr. Husney will get into details more about the newer agents right now. So my point to you that I want to emphasize is that this is a disease that have devastating impact on quality of life and even lower mortality, that we have made significant advances, but we still have a long way to go. And by partnering with the National Psoriasis Foundation, we've not only been able to fund valuable research for ourselves and others, but also to reach out to our patients in ways that we couldn't do on our own. So with that, I'll turn it over to Randy, who can introduce Dr. Husney.
Thank you, Chris. Our next speaker is Dr. Elaine Husney, who is Vice Chair of Rheumatology and Director of the Arthritis and Musculoskeletal Center at Case Western University. She's also a staff physician in the Orthopedic and Rheumatologic Institute at the Cleveland Clinic. She's assistant professor at the Cleveland Clinic Lerner College of Medicine at Case Western University. Dr. Husney's research includes examining health outcomes of patients with rheumatoid arthritis and psoriatic arthritis, specifically in the area of cardiovascular disease. She's a current recipient of the Clinical Investigator Award by the American College of Rheumatology. She is also, like Chris, is a member of the National Psoriasis Foundation Medical Board. So please welcome Dr. Husney.
Hi, good evening, everyone. It's a pleasure to be here, and I really want to thank the NPF for hosting this. I do want to tell you a small story that I have been doing a session at the American College of Rheumatology for several years now on psoriatic arthritis. And when I started this, I don't know, maybe 4 or 5 years ago, the room was only half filled for people who'd want to sign up for these Meet the Professors. And I just want to tell you that this year, when I did it, both my sessions are sold out. So I think it kind of explains where we are in psoriatic arthritis and how interested people are, and to have the NPF really take a focus on not only psoriasis but psoriatic arthritis is really wonderful to see. So I'm happy to also take the stage here with Dr. Richland, who has been a great mentor in this field and has been a leader in GRAPPA and other organizations to study this. So I'm going to talk a little bit more about treatment, and how do I forward my slides? Oh, you are. Okay. All right. Oh, it's just going to happen on its own. Okay. So basically, a lot of the treatments that were used for psoriatic arthritis in the years past has really been borrowed from rheumatoid arthritis, another inflammatory arthritis. And so as we are learning more about PSA, we understand that this needs to be different paradigm, and not every treatment that we use for RA is always going to work for PSA. So optimizing the management of this disease has been limited due to the limitations of the randomized clinical trials, and also, pharmacologic management has slowly been trying to have some consensus between the AACR, between the EULAR and GRAPPA organizations that I'll talk about shortly. Next slide. So here, I think Dr. Richland alluded to GRAPPA, which is a research organization with researchers all over the world that are interested in studying psoriatic arthritis. And what we've really done is base some treatment on really what some of the predominant symptoms are. So you got a sense from Dr. Richland that this disease is quite heterogeneous. There are many, many manifestations that a patient can have, and that's probably some of the problems we're having in terms of looking at outcomes. So this is kind of a busy slide, but just to show you your column on the right looking at peripheral arthritis, skin disease, spine disease, enthesitis, and dactylitis. So anybody could have a combination of these, or maybe just a predominant area in one part, such as the axial or spinal disease. And this is a grid that's used to kind of make a more composite picture of psoriatic arthritis. So I think you can appreciate the sort of spectrum that one patient can have. And Dr. Richland showed a picture of a hand that can have many different aspects even within peripheral arthritis. Next slide. So some of the new drugs that I'm going to concentrate on, you heard a little bit about anti-TNF, and that is one of the major drugs that we use and has really been a game changer. But as you've heard, many people, not all people respond to this treatment. These are some of the new treatments. It's been pretty exciting because in the past couple months we've heard a little bit more about ustekinumab. The dermatologists are probably very used to using this medication because it's been approved for psoriasis, but for us as rheumatologists, this has only been recently approved. Some of the other IL-17 blockers, as you see in the top half, cytokine inhibitors, are also in some early phase studies. Then we'll move down to the bottom of the chart, and you see small molecules. So small molecules have been also a new treatment paradigm. Primolas and tofacitinib has also been coming further along in their research as well, and I'll talk a little bit more about that. Next slide. So just looking at small molecules and biologics, this is just highlighting some of the differences. As we know, not everybody responds to anti-TNF, and therefore small molecules may have a role moving forward. So biologics are mostly injectable or infusional medications, while the small molecules are oral molecules that you take twice a day. Next slide. So the two that are now very widely publicized here at our meeting that I'll just mention is the JAK inhibitors. which inhibit the inflammatory mediators and cytokines, and then the phosphodiesterase 4 inhibitors, which is also another small molecule that can increase cyclic ANP levels. Next slide. So here's just a cartoon drawing to go over the two small molecules. The first one I'm going to talk about is the JAK-STAT signaling pathway. So these small molecules all work by affecting and modulating an immune cell's response to how they're going to stop or promote cellular cytokines and messenger systems. So here we have some cell receptors at the top. You see the purple-blue spike cell receptors. And tofacitinib is one of the small molecules that's been pretty well studied in RA now and approved for rheumatoid arthritis, but only early stages in the psoriatic arthritis world. So you can block there's several JAK kinases. There's JAK 1, 2, and 3. Tofacitinib here you can see blocks 1 and 2, and then downregulates some of the inflammatory or pro-inflammatory cytokines. Next slide. And then in contrast, this is looking at phosphodiesterase 4. This is, so you see the PDE4, which is in the middle in the green. I'm sorry, I don't have a pointer. And I know this is kind of a busy slide, but just try to understand that there's a lot of cascades of pro-inflammatory cytokines that can happen within the cell, and so many of these small molecules will target to try to block some of these. So if you pay attention to the green dot in the middle, the PDE4, apremilast, that's its sort of target inhibitor. It inhibits PDE4 and then allows for more cyclic AMP, which then can help suppress some of the pro-inflammatory cytokines. And if you look all the way to your left, you'll see the pro-inflammatory cytokines that we're talking about are TNF-alpha, IL-23, and interferon. Next slide. This is sort of a little more simpler diagram of an immune cell, looking at modulating the cyclic AMP levels within an immune cell, and this is what PDE4 targets. Next slide. You can keep going. So I thought maybe I'd spend some time to highlight some of the data from the ACR meetings. I do want to thank the MPF for getting me out of the convention center, because I think I've been there for 12 to 14 hours a day for the past 2-3. I didn't know there was anything else to see in San Diego. So thank you for getting me out of that convention center. I mean, many of you are attending this conference, and there are going to be speakers that will, really hone in on some of these issues. But Dr. originally talked about quality of life, so I picked a couple abstracts just to highlight. We are really trying to better understand the real impact from a patient perspective, and I'm really glad that the MPF has a patient here today who we're going to hear from shortly, but to really highlight what people in the real world taking these meds, seeing a primary care, seeing a rheumatologist, seeing a dermatologist, and what do they feel. So many times I was sort of taught in medical school that perhaps rheumatoid arthritis is a more progressive, faster, ongoing inflammatory arthritis, and psoriatic arthritis might be a slower, less invasive sort of disease. And I think as we're studying this, we're realizing that, at least in this particular survey, with the help of the MPF, looks like psoriatic arthritis patients can be just as aggressive as rheumatoid arthritis, and I think that message needs to come out. And despite the targeted treatments that they're on, patients are still not doing as well. They're still having missed days of work. They're still having problems with their quality of life, and being part of a family member just from fatigue and sleep and other issues. Next slide. So speaking of fatigue, there was also an abstract looking more specifically at patients with chronic rheumatic diseases, and looking at the problems that people can have with sleep. And this is a very unrecognized area. And, as we all know, if any of us are up in the middle of the night, your next day is awful. And, imagine these people that are having bad nights one after another. Next slide. So the other sort of big highlights is there has been some longer-term data looking at this PDE4 that I talked about, apremilast, going out to 52 weeks. So they have data from now in PALIS 4. So we've been following the story for a little while, and it's very exciting to have longer-term data and a new treatment option for psoriatic arthritis. So this is looking at a phase 3 randomized controlled trial. Next slide. So here's just some data from the abstract showing compared to placebo, and then 2 different doses of apremilast, 20 milligrams BID and 30 milligrams BID, which is just twice a day oral molecule. Next slide. So this is looking further along into the 52-week study group. So I do have to mention that the 2 different colors represents the 2 different doses right now in the phase 3 trial and carrying it out to 52 weeks. As you can see, though, at the numbers on the bottom, that I believe after about week 16 or 24, the placebo phase ends, and only the patients that remain in open label remain in this trial. So what that means is that the second half of the slide on the right, if you look at the numbers, it starts off, much higher in the 150 range, and then as you go out towards the right of the slide, it drops down to about 70 patients that are left in the open label. So we're not really following all 180 patients or 50 patients moving forward, only the ones that remain, but those that remain do achieve some success with this drug. Next slide. So here is just some more data on apremilast, looking that they have durable improvements through 52 weeks. They did not show a lot of serious adverse events as well. Next slide. Just a pictorial of the same thing I just told you, looking over to 52 weeks. Next slide. So in summary, I think what we really would like you guys to know and hear is that there are still treatment gaps that are out there, that psoriatic arthritis not only affects the skin and the joints, but I hope to show you that quality of life is also severely affected and that we need to address those. And then most importantly is that there are other options now that could be available, and ustekinumab and one of the new TNF inhibitors has also been approved for psoriatic arthritis. So these are exciting times for us.
Thank you, Elaine. Well, you've heard so far about the burden of the disease and just kind of the raw numbers, and heard about current state of treatment options and kind of a look ahead to what's coming. But we all do this for a reason, and this part of the program is going to shift to why the National Psoriasis Foundation does what it does, and why Dr. Richland does what he does, and Dr. Husney does what she does. So we're going to invite Noelia Ferreira to come and share some of her story about what it's like to live with psoriatic arthritis. She was diagnosed at age 24, and she's currently a member of the National Psoriasis Foundation San Diego Division as an active volunteer, and we appreciate her being here tonight to share her experience with psoriatic arthritis. So welcome, Noelia.
Hello. Thank you, Randy. Thank you guys for having me here. I'm really excited. To tell you a little bit about me, I was diagnosed first with psoriasis when I was 13 years old. It took me a couple years to get diagnosed, which was very frustrating for myself and for my family, going from doctor to doctor attempting to get diagnosed. In my early 20s, I started feeling tired all the time, and not just a normal day-to-day tired, just completely exhausted and fatigued, and all the time I just felt like I couldn't function like a normal person. On top of this, I was just feeling achy all the time, especially in the morning. My joints, my hands would turn tomato red and get completely swollen, and so would my feet. And I knew that something was wrong. I knew that there was a possibility that I could get psoriatic arthritis, since I did have psoriasis, and I do have psoriasis, but I didn't think that at the age of 24 I'd be diagnosed with psoriatic arthritis. To be honest, at first I was really relieved, because it took me so long to get diagnosed that I wasn't getting the treatment that I needed. So I was just happy to be finally getting, the treatment that I deserved. And in my mind, I believed that this would answer all my problems. But soon I kind of found out what it would mean for me. I had to reorganize my life completely. I worked full-time, I went to school full-time, and that's a lot for someone, especially someone with psoriatic arthritis. I knew that I had to cut down. So it was hard because I realized that I couldn't do it all, that I had to learn to say no. Instead of always being available for my friends, for family, for school, for work, I had to learn to prioritize. I can't go out past 10 o'clock at night if I have to be at work early in the morning. And on top of this, it's hard to explain it to people. It's hard to tell your work. It's hard to tell your friends. It's hard to say, no, I can't do this today, or no, I can't be available to go out with you because I'm flaring today. I don't feel well today. People don't understand, and especially when you're younger, it's hard for them to kind of figure out what that means or how you feel. What did really help me was the National Psoriasis Foundation, getting involved, meeting people that had psoriasis or both psoriasis and psoriatic arthritis really helps because they help you cope, you help them cope. You all have different kind of mechanisms of how to deal with it, with different things. And I hope that maybe this was helpful for you guys to understand like what living with psoriatic arthritis is like. And for sure, if you have any questions, if I missed anything, please let me know and ask me. Thank you.
Thank you, Noelia. That concludes the presentation portion of our program, but we have a few minutes left for questions that you may have. Anyone have a question for any one of the panelists, or if you just have a general question, I'll do my best to triage it. If you would like to write down a question rather than ask it, someone's coming around with cards, you can simply write down your question. So, anyone? It's always hardest to go first. Yes, right here.
In terms of this problem of early diagnosis, what can be done about improving it? There seems a huge gap. I mean, is it the fault of clinicians?
Well, I think there's a lot of forces at work that contribute to this gap, and I'll offer to both Doctors Richland and Husney their perspective on what that gap is, and then chime in with what we see as some of the issues at the National Psoriasis Foundation.
So I think one of the major problems is that it is so diverse in presentation, the arthritis, and that there are no definitive blood markers for the disease. So in the case of rheumatoid arthritis, one has a blood test that you can order, rheumatoid factor or anti-citrulline polypeptide antibody. We don't have that in psoriatic arthritis. And it can present as a tendinitis, as a swollen digit, as an arthritic digit, as back pain. So all of those can escape notice. I think that if you were to ask me what would be the best way to try and speed up diagnosis, it would be educating patients, obviously, and people like Phil Mickelson, who have psoriatic arthritis, has been a great boon to getting the word out among people. The National Psoriasis Foundation has been marvelous in that way, and I think that's one way. And the second way is to increase the awareness among physicians, and in particular dermatologists. And someone who's sitting to my left has been very key in developing questionnaires that can be put into dermatologist's office that I think can help make that diagnosis early, and Dr. Husney can talk to that.
I agree with what Dr. Richland has just said. I think this idea of co-management, and the reason I bring that up is that psoriatic arthritis, unlike many other diseases, can transect both a rheumatologist and a dermatologist. So you can imagine that that's difficult because many patients choose one or the other doctor to go to first when they have symptoms. And so I don't know if Noelle probably had a similar situation where, many of these patients are seen by the dermatologist. So one of my areas of research is to create a self sort of questionnaire that helps patients be aware and diagnose. If you score over a certain percentage, like 47, then they can be referred to a rheumatologist. Those are just one, sort of tools that you could use to speed up diagnoses.
Noelia, you have any thoughts on how this disease can be diagnosed earlier?
It's complicated because of what she was saying. I have a primary care physician, then I have a dermatologist, and I have a rheumatologist. So to get all those three people to combine and to find something or to even agree is very complicated. So I think that that's an issue.
Okay. Other questions? Yes.
Is there a platform where doctors and maybe patients share their knowledge to get more, to spread the news how to diagnose people?
I'll allow our physicians on the panel to comment, but you teed it up perfectly for the National Psoriasis Foundation. And by going to psoriasis.org, we have a community, a platform. It's primarily focused for patients, but it is called Talk Psoriasis, and we have patients across the globe, some 35,000 and counting, who visit regularly to share their own disease management experience and seek help from others. I do know there's a number of healthcare professionals that do visit the site just to see what's on patients' minds, but it really is focused for patients. So I know Doctors Richland and Husney are members of ACR and a lot of other organizations that probably provide that format, but I'll let them comment on that.
So, very important question, by the way. There is an organization called IFPA, International Federation of Psoriasis Associations, which has a Psoriatic Arthritis Psoriasis International meeting in Sweden every 3 years, of which there are organizations from around the world that NPF has a prominent role there, that help psoriatic arthritis patients. And there's dermatologists, there's rheumatologists, and all sorts of caregivers at every level for patients with psoriatic arthritis. And this is really quite an amazing meeting because you have very top science being discussed, you have clinical care, and then you have all the patient organizations from around the world sort of getting their resources together and talking about what works for them and what doesn't work. And so that organization, along with GRAPPA, which I'll let Dr. Husney talk about, I think have been really clearinghouses for allowing people, both patients, by the way, and clinicians, to discuss this disease at many levels.
One of the events that I have been peripherally involved in that includes the NPF is they have a program that focuses on trainees in dermatology, and so that's one way that I could think of that's really made a difference. So what happens at that time is they are allowing younger physicians to really be aware and understand how to screen, what to look for, because sometimes with all the things that we're trying to learn and all the antibiotics and medicines that are out there, it gets difficult during a short training period to know about everything. So the NPF has been really helpful in allowing different resident trainee opportunities, and both Dr. Richland and I have participated in those events. So I think we are really making headway moving forward. I do think it's a great question. We probably can't just do it in one day, and so these are some examples of, I think, how we're really making big waves moving forward with trying to raise awareness on different levels.
Yes.
Does early treatment have an effect on the natural history of the disease?
I think we are, especially in rheumatoid arthritis, where we have the data for early disease, I do think that there are many studies that are showing changes and helpful in terms of radiographic progression. I think in psoriatic arthritis, our studies are lagging a little behind, but I do think that, there's a window of opportunity where we can, treat this disease earlier and prevent comorbidities. We didn't get a chance to really talk about the cardiovascular risks, the comorbidities that can occur with sort of longer-term uncontrolled disease. So I think that would be one area that would be very important.
At this meeting, Laura Coates from Leeds, England, presented what's called the TICOPA study, which is tight control of psoriatic arthritis. And I think she showed in a very well-designed study that a treatment of a fairly early group aggressively with clearly defined milestones can improve outcomes. And it's the first study, it's presented at this meeting, but I think it's going to be a model for other studies that come. And the other point to remember is that psoriatic arthritis has only been defined as a disease for 40 years. It was in 1973 that the first manuscript came out of England that really defined the essence of this disease. And it wasn't until 1998 that we really had therapies that were even modestly effective. And we've come a very long way, and you've heard from Dr. Husney that we have a whole host of new agents now that are going to be available to patients with this disease. So it's a very exciting time, and it's one in which we have great hope that by early intervention we will make a difference. And again, the TICORA study seemed to TICOPA give us hope that that might be true.
Other questions? Yes.
In terms of apremilast and the Pfizer treatments as well, the JAK, where do you see them fitting into the treatment paradigm?
So apremilast is an agent that's oral, which is an advantage over many other drugs that are currently being used in psoriatic arthritis. It is a drug that has a very low side effect profile, which is a major advantage. And so I think that it has the potential to be used early in the treatment regimen for psoriatic arthritis with a couple of caveats. The first caveat is how well it's priced. So, you know, these drugs are expensive, but if it was priced competitively, that would put it way up on the current market, which is extremely expensive, in the range of $28,000 a year for a medication. Secondly, I think that this drug, while very effective for the signs and symptoms of the skin and the joint disease, is not effective for people that have damaged joints. So if you have someone that comes in, and we've already shown you that within 2 years you can have half the patients have damage, apremilast would not be a medication you should put them in. So for patients that don't have damage to their joints, and in the right price range, I think that this drug could be a major advance in psoriatic arthritis. Would you agree with that?
I would agree.
It also works for psoriasis, by the way, which we didn't mention.
Right.
Yes, in the back row.
I have a couple of questions regarding reimbursement. First, would you put a patient on a less effective and product with more side effects because it was covered by insurance as opposed to a drug that was more effective and had less side effects?
No.
All right, so the second question is it a matter of pricing or is it a matter of how the insurance companies are pricing these products to the patients and thereby exposing them to making a choice between less effective treatments that are covered and more effective treatments that are not?
Oh, I'm not sure this is, on the insurance companies. And I mean, there's a lot of, we could talk a long time about this. I think it's a complex maze right now. But my point, the major point that I have to say about the biologics is that their cost is now excluding many patients from being able to use them. And as coverage for these drugs becomes more difficult, and that's in the United States, worldwide it's a much bigger problem. But the thing, we really want to use drugs that are effective, and we're not going to sort of try and cheat the patient because to go for the cheaper alternative. But to be frank, there are many companies, many insurance policies now that just aren't going to pay that kind of money for an agent on a chronic basis. So this is what we struggle with through the National Psoriasis Foundation, at the Cleveland Clinic, at University of Rochester Medical Center. And to add to that fact, these patients have psoriasis, which is a disease which is severe enough as it is. And there are treatments for psoriasis, such as phototherapy, which are actually quite cheap compared to the alternative, and yet insurance companies charge copays that make it unavailable for patients to use. So the whole psoriasis, psoriatic arthritis, compensation, reimbursement is very complicated, and I know the MPF has been lobbying and working very hard to sort of improve this availability for these treatments for patients, and we need to continue to do that.
I think in treating patients, it's not really one or the other all the time, right? So somebody might start on something, and if they don't do well, then, you know, we appeal and they go on to the next drug. So it's not as a simple corollary right at the beginning, we, you know, decide whether you go on a TNF or a Primolas. It's also what your primary manifestation is of the disease and, you know, how we start. So there's a lot of other, I think, decision model of care that goes in than simply just A, B pricing, and then you're done, right? So we look at which parts are affected. You know, some drugs might be better in enthesitis, and if that's your primary manifestation of the disease, then, you know, that's you know, how you make decisions. So I think it's a little more complicated than just into pricing and biologic or small molecule.
And at the National Psoriasis Foundation, we see it much simpler than that, in that we feel that the decisions, clinical decisions, should be made by the physician and the patient. It's that simple. But it is a very complex landscape that we spend an awful lot of time trying to work our way through. But we feel very strongly about that physician-patient relationship. Other questions? Okay. I think there's still some refreshments left outside, and if you want to spend a few minutes, I know or all of our panelists will be around for just a couple more minutes if you'd like to ask some questions individually. Thank you all for attending. Please, a round of applause for our panelists tonight. And thank you all for coming.